Four important imaging modalities we currently use: endoscopic ultrasound, especially for early gastric cancers where endoscopic mucosal resection is performed. CT and PET CT would be the mainstay of course, and sometimes MR can be done, especially when you can't give IV contrast, but MR would not be the dominant modality, though it would be good enough in differentiating the various T characteristics and the metastatic, distant metastases in the abdomen. Now, very important to have adequate luminal distension of the stomach whenever you are trying to detect tumors, because a collapsed stomach could mimic a gastric cancer. You could distend the lumen either with a positive oral contrast, the routine X-ray water-soluble contrast, or most preferably nowadays we use a neutral contrast, be it plain water, or sometimes you can use mannitol diluted with water as well. So that's very important. So the normal appearance would be that when the stomach is adequately distended, this is with water, a neutral contrast agent, it's very imperceptible. It's 1 to 2 millimeters in thickness. And whenever the thickness increases, especially more than 5 millimeters, whether it's focal, it's nodular, it's irregular, then you tend to think of a malignancy, especially in a focal. So this is an example of a severe thickening. As compared to the wall, which is well distended in the rest of the stomach, you have an irregular nodular thickening of the stomach. There's also perigastric infiltration suggesting a serosal extension. There is also an enlarged lymph node. So a focal thickening more than 5 millimeters, which enhances, that's pretty suspicious for a gastric cancer. Now, coming to the T1, especially T1A endoscopic ultrasound, T1B endoscopic ultrasound would score, but for T2, T3, and T4 lesions, CT would be good enough. So whenever we have a T2 lesion, which would show as thickening of the stomach wall, which involves more than 50% of the stomach wall. So we have a focal thickening here, but you tend to see that the outer margin of the serosal aspect is normal. Then there's also a remnant stomach component which is seen, implying that this is a T2 lesion with intact perigastric fat planes and an intact outer wall. Now, vis-a-vis a T3 lesion, which is a transmural extension, we find that there's an interlesion which is involving all the layers of the stomach, implying that it's a T3 lesion. The outer margin is normal. There's no perigastric spread, implying that it's a subserosal disease and not a serosal extension. Now, T4A lesions have breached the serosa. So we have a lesion like this here in the lesser sac, a large polypoidal type of lesion, which is extending into the lesser sac and into the gastrohepatic omentum here with fat stranding. And another example here, an stricturous lesion with a nodular thickening in the antrum with features of gastric outlet obstruction. Again, there is extension of the disease into the perigastric fat planes, and an enlarged lymph node is also seen adjacent to the pylorus. Now, one sign which has been described recently is called as the high enhanced serosa sign on CT, where whenever you have a thickening of the tumor and you find an enhancing serosa at that point of thickening or the presence of tumor, and this sign has been found to be very sensitive as well as accurate to identify extraserosal spread of cancer, especially in T4A lesions. Of course, when you have an irregular nodular extension to the adjacent gastric mucosa and haziness of the perigastric fat, that's a very classic marker of T4 disease. Now, T4B is extension of the tumor from the gastric tumor into the adjacent organs. Most often it extends along the gastrocolic ligament into the head of the pancreas and into the colon. So we have a disease in the stomach, large disease here extending into the head of pancreas. You don't find the normal fat planes there. In addition, you also have enlarged lymph nodes here, as well as biliary dilatation due to the porta hepatis infiltration and also liver metastasis in this particular instance. Now, coming to end disease, the nodal disease, the size criteria, there's no universally accepted size denomination, but 6 to 10 millimeters has been the size criteria. Shape, whenever the normal lymph nodes are oval in shape, whenever you have a round shape, then that's a marker for a suspicious metastatic involvement. A cluster of 3 nodes, even though they are small in size, could be a marker. And enhancement, enhancing lymph node, especially with areas of necrosis like this here. You find the tumor in the lesser curvature of the stomach, you have these large bulky nodes. Of course, they are enlarged by CT criteria of size, but you also find in the smaller nodes you have this central necrosis, which is again a marker of a nodal involvement by the gastric cancer. Again, other examples showing that the necrotic lymph nodes at the celiac axis, and also in the lesser omentum here, apart from metastases and biliary dilatation.